think today's a real red letter day for folks who are concerned about Ebola. In Dallas, Texas, they've released from quarantine nearly all of the persons who had contact with Mr. Eric Duncan prior to him being hospitalized. The only people who remain in quarantine are just a few of the healthcare workers that had contact with him before the full protective gear could be utilized. So persons that were in close contact with Mr. Duncan, even those who lived with him in a small apartment, have not contracted Ebola virus. And I think that this is very reassuring to folks in our community who have concern about Ebola, and should hopefully help to alleviate some of those concerns, some of that irrational fear that we've been seeing running so rampant now. And I'm sure that you guys are aware of the examples of cruise ship not being able to dock, airplanes that are being quarantined, schools that are being closed. We even have some examples here in our own community of children of parents who are working in our biocontainment unit being shunned. This is just totally irrational, and I'm really hoping to get the word out that that level of paranoia is just not helpful, and it's just not appropriate. What we know about this virus, and what again has been emphasized, is that when people are in the early stages of Ebola, they're not very contagious. When they're not having any symptoms, they are at zero risk. They really don't spread the virus at that stage. And even when they start to have symptoms, like we saw with Mr. Duncan, he's not spreading it to the people living in close confines with him. This should be very reassuring that you don't pick up Ebola from riding a school bus, from taking an airplane ride, from passing somebody in the grocery store. This is only spread through direct contact with blood and body fluids, typically in somebody who has advanced disease. And unfortunately, that's the other lesson that we learned out of Dallas, is that when somebody has advanced disease and is in that phase where they're having a lot of shedding of the virus, that's when they become most dangerous for our healthcare providers. And that's why we have the unit here at the Nebraska Medical Center that is specifically designed to safely care for these types of patients. So I'd be happy to take any specific questions that you might have.
With these dozens of people now being able to not being quarantined anymore, are we kind of seeing maybe the downside or the downward of the hysteria and with people that was close to Thomas Eric Duncan being cleared, like are hopefully seeing the not many cases anymore here in America at least?
Yeah, so the condition remains very severe in West Africa, as you know. We're continuing to see increasing numbers of cases, and so I think our country is appropriately responding and trying to combat that epidemic in West Africa so we don't have to combat it here. I'm hopeful that this case that we're discussing today, with the release of quarantine of people who are even living in close confines in a small apartment for several days with somebody at the early stages of Ebola, help to really allay the fear that this virus is spread from casual contact. It just doesn't spread that way. It's not an airborne virus. It's not spread through the air. It's spread through direct contact with blood and body fluids. And you can be in close contact with somebody. You can be sitting next to them. You can be even living in the apartment with them for 2 or 3 days and not catch this virus.
Now, what reason would there be to quarantine? We see people claim to have Ebola or claim to have symptoms, and quarantines go up. Is there a guideline that say you need a diagnosis first? What's overreacting and what's not?
Hospitals all across America and clinics all across America are now developing ways of screening patients. Typically, this is through a combination of screening them for travel. So there's a handful of West African nations that you're familiar with. If you've traveled to one of those areas and you're within that 21-day period of incubation and you have symptoms, so fevers, chills, malaise, muscle aches, all these symptoms that we talk about, then that triggers much closer scrutiny and taking it very seriously. Clearly, if you've traveled to one of those countries and you were there 3 months ago and you get sick, that's not Ebola. Clearly, if you come into the clinic and you've traveled there but you're not having any symptoms, that's not any danger for transmission. So these are the things that we're learning. These are the things that emergency departments and clinics will be screening for.
What has what have you guys learned with this virus and how it spreads and how quickly people show signs and symptoms? What has this taught you guys?
Well, you obviously do have to have a healthy respect for this virus. I mean, this clearly is a virus with a high mortality rate, albeit not very contagious. So we've learned that in the early stages, that is not very contagious. In the later stages of disease, it becomes more contagious as you have increased shedding of viral-laden secretions and fluids. So we've learned to be very careful with these patients when they get into our hospitals, into our clinics, into our ICUs, that we do have to care for them with the appropriate precautions, but that we can do that safely.
Now you and your team have become kind of the gold standard for treating someone with Ebola. How proud of you are you with the members of your team, the men and women who care for these patients on a daily basis?
Well, I think all of us here at the Nebraska Medical Center, Nebraska Medicine, and hopefully throughout the community are extremely proud of these individuals. I think that it shows great foresight from a number of individuals here at the institution that they've put together this unit and this team and how useful it is now to our nation in a time of need.
And you're able to give a little update on our patient here in Omaha.
Yeah, the patient that we're caring for here, which is our second Ebola patient, is doing quite well, recovering. We're waiting for some confirmatory tests to show that he's actually completely cleared the virus, and we're hopeful that he'll be getting out of our unit in the coming days. He is going through that convalescent stage that we have noted in other patients, where it is a serious disease. They're pretty weak, they're pretty worn down. It's going to take a little bit of time for him to bounce back, but he's doing quite well.
Do you think I guess any time frame as to when he could be going home?
Well, it really depends upon how fast we can get some confirmatory testing of him having this virus out of his system. Those tests have to be run through the CDC, so it takes a few days to get there and get back. So we're hopeful maybe sometime later this week, but we'll just have to play it day by day.
Speaking of the CDC, what's your reaction to how they've maybe failed to respond initially? They've even kind of admitted that, and then how they're responding now. What's your reaction?
Yeah, I think that the CDC is learning somewhat as we go, like all of us. I think that, unfortunately, prior to the Presbyterian Hospital experience, that had we had all of our emergency departments and clinics and ICUs drilling in how to safely care for an Ebola patient, the general response probably would have been a rolling of the eyes and are you kidding me? We really have to do this. Obviously that's changed now, and people are taking this seriously, and so people are putting those plans into place and are getting the precautions set up so that they can safely care for these patients for a period of time, potentially sending them either to biocontainment units or other settings in their hospital that are prepared to care for them. So I think that we've all learned a lot throughout the country over these first few cases, and particularly with Mr. Duncan and the spread to some healthcare workers. So those precautions are now being ratcheted up appropriately, and we're going to do a better job in caring for these people all across the country now.
Do you see the future for any of the current Ebola patients to be transferred here to Nebraska Med?
Well, I'm not aware of any plans at the present that there's transfer plans. I think that we're going to become more adept at caring for folks with Ebola throughout the country, and that our larger hospitals are going to be well equipped to deal with these folks.
So will that mean a smaller role for the unit here and stuff, or do you expect to continue to see patients as this outbreak continues? Or
well, I suspect that our unit will continue to be called into action, particularly as we have a defined case that needs to be transferred, particularly from West Africa. I think hospitals in the U.S. are going to become better prepared, but I also see a big role for our center in telling other people how to do this safely. And so clearly we're one of the models for that, and being able to take our experience, translate it into teaching materials for hospitals really all around the world is one of our primary roles now.
How do you, I guess in your opinion, how do you determine when a patient should be transferred to a unit as specialized like this one, which is, there's only a handful in the country, and now that there's been more being done at different hospitals to better be equipped with treating patients, I guess, how do you determine when a patient should stay where he or she is and then when it's necessary to be transferred here?
Yeah, so I think that clearly illustrates the problems with just having a few units where you're trying to take care of everybody. That we will quickly run out of capacity in the 3 biocontainment units that are up and running. Ourselves here at Nebraska Medical Center, the Emory unit, and the one at the NIH. We have a combined capacity of somewhere probably in the neighborhood of 6 to maybe 8 patients. Clearly that's not enough if this thing continues to spread. Now, we're hopeful that there will be very, very few cases that are coming into the United States, particularly unannounced, if you will. So again, when we know somebody has Ebola, we safely transfer them from West Africa. That's a situation where we have everything contained, everything controlled. The situation that I think is still one that we need to work on in the country is when people come in unannounced, potentially, to emergency departments, and that's where we need to continue to work to develop well-trained, well-staffed groups of folks in various hospitals across the country that are adept at evaluating these patients and safely caring for them. We simply can't, every time one of these people comes in, transfer them to a biocontainment unit.
With what you've learned over the past couple months with treating these patients, what can be taken back to West Africa to help combat this or to help kind of keep this under control, where they don't have a lot of the resources that we in America have?
Yeah, so that is an issue, obviously. When you're trying to do containment of an outbreak involving now thousands and thousands of persons that we anticipate is going to go over the longer haul. This is obviously a marathon. It's no longer a sprint to contain a small outbreak like they did perhaps in Nigeria or Senegal. We're talking about a large group of people who are potentially exposed, potentially having infection. And that's where, again, I think our country is playing a very big role, building some of these Ebola containment hospitals, and even more importantly, training a cadre of public health of how you do the contact tracing, how you do the quarantine, how you slow down the progression of this virus. And then I'm very hopeful that this has really demonstrated the need for some of our medications and some of our vaccine development. I've heard some reports very optimistically that here within the next few months we're going to have some candidate vaccine that's going to be delivered, not in the 1 or 2 dose range, but we're talking about hundreds of thousands of doses that may really be able to help stem the tide of this outbreak. But we're in it for a longer haul.
I know you're treating patients here, obviously, but are you working on any type of research and developing these vaccines here?
So with each of the cases that's come into the United States, they've been looked at as a potential learning vehicle, clearly. That's one of the missions of an academic medical center, is that we need to try to learn how to best care for these patients. So each of these patients has received some investigational agents. Each of them have received infusions of the immune sera from previous survivors. We're trying to sort out which of these modalities is going to be giving us the most beneficial effect. That's hard to figure out in very small numbers of patients, but in each and every patient we've learned a little bit more.
Do you foresee sending any of your staff over to West Africa?
Well, clearly we have our hands full here. I don't see there being a large contingent of folks coming from the Nebraska Medical Center to go to West Africa. Clearly we do have some expertise, and I think that it's going to be put to best use in some of our educational efforts here in this country.
A question from someone from National Geographic who's watching, I assume. They would like to know if you could address the issue of quarantine in the U.S., when involuntary quarantine is relevant, who you think should be under voluntary/involuntary quarantine in the U.S.
Yeah, so anytime you have a potentially communicable disease, you sort of have two forces at work: people's personal freedom and then the public health interest. I think typically we should have our emphasis on what's in the interest of public health, and so these patients that are potentially exposed even albeit they have a very low risk of contracting the disease, do need to be put into some sort of a watch, a quarantine situation where we can clearly monitor them. I think it becomes something where you might put somebody under involuntary quarantine when they've documented that they're not willing to put up with a voluntary situation. So clearly we can't have people breaking quarantine, traveling all over the place when they are potentially infectious. But clearly when they're not having symptoms, again, these are not contagious persons, and we really would not need to put them into a lockup, for instance, because that's just not the way this disease spreads.
So just to be clear and to verify, if they don't show symptoms, they're not contagious.
That's correct. That's one of the, if there is a silver lining to any of this, is that you don't have a long period of time where you could be spreading and shedding the virus before you feel ill. So you're really not contagious until you start getting sick. And then what we've learned from Mr. Duncan is that you're really not very contagious until you become really sick. So that's a good thing for us in public health, that we do have this little bit of a cushion. We can be watching people closely when they start to show the first signs of disease. We know that they're not very contagious. That's when we can get them into a safer situation.
In your opinion, basically, was it a late diagnosis that basically resulted in him losing his life and then all these people getting the virus?
Well, clearly the earlier you make a diagnosis, the more effectively you can treat somebody. That's true in a bunch of different diseases, including most of our infectious diseases. So we want to stress now that people with these risk factors are going to be evaluated appropriately. Those showing evidence of Ebola virus would be put into a safe environment. They would get tested quickly, and then we would hopefully be able to offer them the supportive care and potentially some of the investigative care that could save their lives.
Here in Nebraska, do you feel like a lot of people have, or any numbers as to how many people have come to the clinics and say, maybe I have symptoms of Ebola, or I'm scared, I just got on a plane recently, anything like that?
Well, again, that's what I'm hoping this release of quarantine from Dallas really helps to allay those fears. That again, simply having, being on the bus, being on the plane, closing schools, preventing cruise ships from docking, these are all just examples of irrational fear. There just is no risk of the transmission of Ebola. There is no risk of that person having Ebola unless they've clearly had documented contact, been in one of those countries during the incubation period, and exhibiting symptoms. So there's just been a lot of fear out there in the community that I'm hopefully will be ratcheting down now as we realize that folks can live in close proximity to somebody with the early stages of Ebola and not contract the disease. So these are folks who are living closely with Mr. Duncan in his apartment for several days while he's exhibiting symptoms and did not contract Ebola. So we need to be really setting the bar at the appropriate level of concern and not having folks canceling schools because the parent traveled on a plane in which the person may have been contagious. I mean, it just simply doesn't spread that way. Having people shunned at parties or soccer games or what have you because their parents are participating in the care of a patient is totally irrational fear. We need to be battling that, getting the education out there and getting people to understand where a rational concern is and where irrational fear is just paralyzing us in our daily lives.
You keep talking about the early stages of the disease and how there's not a great concern with contagious there. Does the calculation change in the later stages of the disease, and as far as how contagious it is, and
So clearly, as people become more ill with Ebola, they go through stages of their disease, and as they get to that stage where they have profuse diarrhea, vomiting, bleeding, all of those fluids contain large amounts of the virus, and this is when they become most contagious. So this is when they would be in the ICU, in our biocontainment unit, and this is clearly where we need to be taking those extra precautions to provide care for them safely, which we've demonstrated is quite capable of doing here.
I guess, do you have any estimates and numbers? Would you say dozens of people have contacted Nebraska Med either through the clinics or calling, concerned that, like you mentioned, that some of the employees are being shunned and people are just over paranoid?
Yeah, so I think hospitals and clinics all across the country are facing this. This is not something that is unique to Nebraska Medicine or to our medical center or our clinics. I think folks all over the community have had an irrational fear of Ebola, thinking that somehow some sort of casual contact passing through the airport in Dallas somehow puts them at risk of Ebola virus. It does not. Clearly, we need to calm that hysteria, get some accurate information out there in the community, allow people to lead their daily lives without this crazy fear that they're going to come into contact with Ebola virus and contract this disease.
Another online question. CDC is expected to issue new guidance to hospitals about personal protective equipment. Did we have any input on those guidelines? What kind of change to the current recommendation, in your opinion, is most needed?
So I think that the CDC has been taking all the information in that they've been able to gather, including information from the Nebraska Medical Center, and they have changed their recommendations on the personal protective equipment for healthcare providers to include essentially coverage from head to toe, all skin surfaces. So this is exactly what we've been using in our biocontainment unit, where we have shoe covers, an impermeable surgical gown. So this isn't the plastic, Tyvek jumpsuits. This is a gown that any hospital has at their disposal. We're wearing a bonnet that covers the head and the neck, along with a full face shield and an N95 respirator, and then 2 pairs of gloves. This is the standard gear that we're using in our biocontainment unit. They have this type of gear in all hospitals in the country.
Would you say Nebraska Med is currently, an international leader when it comes to treating and research for Ebola?
Well, I think clearly we've demonstrated that we're at the forefront of caring for these patients and caring for them safely. Again, we're trying to learn from each and every one of these patients in the United States, so we are contributing to the body of knowledge of what this disease looks like, how it responds to supportive care in an American, United States, Western type of care setting. So yes, I think we are seen as leaders in this field and hopefully have contributed to our knowledge base on the treatment of Ebola virus.
I know hospitals have been turning to you with questions, and doctor, looking online and seeing how you do things. In the future, could you see, some of these hospital directors or some of these doctors coming in and just kind of getting a feel for the way the center looks, or how you guys do things, kind of be, when you're not hosting patients, that model for these other doctors and nurses in hospitals around the country?
Yeah, so we're exploring educational models and trying to be as helpful as we possibly can. Obviously, when we have an active patient in our biocontainment unit, is not the time to be bringing persons in who are untrained. That would be a dangerous situation and not something that we're going to do. So we're looking for platforms in which we can get out as much of our teaching on an electronic format as possible, and then we are hopeful to be able to serve as potentially a training site in other ways as well.
What do you think it'll take to kind of calm everybody's fears kind of once and for all? I mean, with this, of course, being in the news, of course, hospitals, every type of area is kind of taking their own precautions. What do you think it'll take kind of once and for all to silence those myths and just kind of put everybody at ease?
Well, I think that, this lifting of the quarantine in Dallas should go a really long ways of allaying people's irrational fear of Ebola. Clearly, these folks were living in close contact with Mr. Duncan in a same small apartment and did not contract the disease. I think that any rational person would look at that evidence and suggest that, gee, I'm not likely to catch Ebola from riding the bus with asymptomatic persons or getting on an airplane or attending the same school or what have you. So hopefully this will really help to ratchet down the fear that we're seeing in our community.